And there are two types of neurological manifestations in MPS II. We've got these problems related to the neural impairment, to the direct damage of the neuron, the neurodegeneration, that is the progressive cognitive impairment and the behavioral manifestations that has. Epileptic seizures are common in Hunter syndrome, could be seen almost in 13% of the cases, and there are a clear difference between the severe phenotype or neuropathy phenotype and the attenuated or non-neuropathic phenotype. But it's in the attenuated patients also something that could appear in the course of the disease. Epilepsy in general, or seizures in general, has an incidence of less than 1%. So it's an increased risk of seizures in any Hunter patient. And which kind of seizures? There is no specific pattern of epilepsy in Hunter syndrome. Mostly there are generalized tonic-clonic seizures, but also we can see myoclonic seizures and absence, stirring episodes that are sometimes very difficult to assess, because you have to remember these patients are usually with social contact impaired. They are mentally handicapped with a behavior very disruptive. So let's talk a little bit about these stirring episodes or subtle absence or seizures that could be maybe an overlooked manifestation of Hunter syndrome. Fortunately, the seizures in Hunter could be managed quite easily. There's not such a refractory epilepsy described. I will tell you another very interesting case about a female Hunter patient who was 7 years old, and he showed sudden neurological deterioration with a sleep disorder, with a behavioral impairment, and an EEG was done showing this permanent discharge in the frontal lobe, something that neurologists know that non-convulsive neurological status. It's an epileptic status, but with no clinical seizure. Could be an anecdotal report, but it's something that should be kept in mind, because maybe it's an underdiagnosed problem, because we do not perform EEG in a serious way routinely for all the severe neurological patients with Hunter syndrome. But we should we should assess our patients with sleep studies, because mainly by the ENT and the respiratory symptoms, we have to remember that this is a normal sleep pattern. We start with a slow sleep until the first middle of the night. We start to enter in REM situation, and it's very impaired, this architecture in Hunter syndrome, due to the microarousals due to apneas. What I would like to stress here is that when you ask for a sleep study, don't do it just for an ENT suggestion, an ENT basis, but also for neurological, because the sleep study also has a very, very rich information in terms of EEG. Let's talk about hydrocephalus, another common neurological problem in MPSs, especially the communicating hydrocephalus in Hunter in MPS II. It's not very common, but it's a life-threatening complications. What's the mechanism of production of this hydrocephalus, this enlargement of the ventricular cavities here? Well, the proposal mechanism is the impaired reabsorption of the CSF, of the cerebrospinal fluid, due to an arachnoid plexus deposits of GAGs that, of course, impair the reabsorption. But it's a very slow or subtle, it's a chronic, insidious manifestation. Many times it's not always an acute crisis that could give you an alert to look for actively. So keep it in mind. To diagnose a hydrocephalus, you need an imaging. Which kind of imaging? It depends, of course, of the technology you have available at your center. And of course, we've got pros and cons related to the procedure itself. MRI, it takes longer, so the anesthetic should be more profound or longer. CT scan could be sometimes done in a few minutes. There are two frequent pitfalls diagnosing hydrocephalus. One is that the atrophy, the brain atrophy, is also very common in MPS II, and it's not only a cortical atrophy, but also could be a central atrophy, something known as ex vacuo hydrocephalus. So you have to be very smart to differentiate. Sometimes you can do it only by imaging, and you need to assess CSF pressure by lumbar puncture. This is one of the problems. The other one is that you can trust in the fundus oculi to know if there is hypertension or not, because papillary edema, the classical sign to diagnose hypertension, could be seen in hunter not related to problems in the CSF pressure, but only in the optic nerve band. So could be a papillary edema without hypertension. What about the treatment? If you find an hydrocephalus, you should call the neurosurgeon quickly, because it's not a simple complication. The treatment is the shunting. The ventricular peritoneal shunting is the more common. You need to be sure that there's a hydrocephalus. So if you don't have evidence of progressive enlargement of the ventricles, and you are doubting about the presence of ex vacuo atrophy, you should perform lumbar puncture and see if the pressure of CSF, the opening pressure, is greater than 25 or 30 centimeters of water. And the procedure, of course, is a surgical procedure, have not only the anesthetic risk, but also specific complications like infections or failures, hematomas, but should be done if necessary, of course. What can we find when we ask for an MRI in a hunter patient? Let's see the problem with severe hunter patient. He was already severely impaired in terms of cognitive function, with IQ less than 40 points. What I found in an MRI, this is very, very classical in a severe hunter patient. You've got here the huge ventriculus, the enlargement of the ventriculus, with also atrophy. You've got enlarged subarachnoidal spaces all around the cortex. And you can see this abnormal intensity in white matter, in periventricular white matter. That is the leukoencephalopathy, very common also in hunter. And if you look well, you also have here some small holes that are very, very common in MPSs in general, that give the brain the aspect of Swiss cheese. And there are perivascular spaces, virtual Roman spaces that are dilated. It's very common in MPSs. But that finding, perivascular dilated spaces, could be found not only in severe patients, but also in attenuated or even in very young patients. Okay, this is a CT scan of a patient. He had severe phenotype as well. It's a very interesting case because for 2 years, when he was 2 years old until 4, he was diagnosed as an autistic boy, PDD, pervasive developmental disorder. When he started to show liver enlargement and some deformity of hands, we found in a few days that was Hunter syndrome that he was suffering from. At age 12 years old, he started to cry much more frequent, all night long, with more abnormal behaviors than before. The parents to the emergency room, suspecting that he was in pain. So after a very comprehensive clinical exam, a CT scan was performed, and what was found was very dramatic enlargement of ventricles, also of the third ventricle there. The ventricular peritoneal shunting was performed in the hospitalization. This gentleman was a universitary student. He sadly passed away 2 years ago with normal IQ. So that's the brain with some periventricular enlargement there, even attenuated, and some little enlargement of ventricles. Well, that's the other side of the spectrum, the other corner of the spectrum, with a very severe phenotype. Now 14 years old, at age 11, he showed this kind of huge enlargement with leukomalacia or white matter abnormalities, and also cortical atrophy. So what would you do with this patient if he's quite well, he's still walking, he has lost language many years ago, and there's nothing new, but you found this ventricular enlargement. You do nothing and just say, well, it's atrophy, just atrophy, or you go for another option, surgery, lumbar puncture.
It is true that this is a compensatory hydrocephalus, but all this white hyperintensity that you see in the periventricular probably is not just a gliosis, but it is probably a pressure that is going beside the periventricular stuff. So this is really, you know, a limit. We should not come to this kind of NMR, because I mean this is obviously a patient that probably was far away and never was checked with time. Unfortunately, the MRI is giving some anesthesiological problem, but I mean we need to check these kind of patients due to the fact that the papilledema is not a reliable sign. And to make a lumbar puncture here, you measure the pressure, but you can also have some problems in equilibrium. So yes, I would put a shunt and regulate it and see what is happening, especially if the child has some dizziness or more problem in the sleeping or whatever. Okay. Because of the intensity in the periventricular space, which is probably the liquid that is going.
So problems about neuroimaging is when to perform it should be done in a routine basis or not. Is it necessary to perform always an MRI when you, for first time, diagnose the patient they've got a baseline image of the brain? There's no consensus on that. That's something that should be maybe discussed further as we know more about the disease and the outcome. So let's talk very briefly and fast forward about spinal cord compression and carpal tunnel syndrome, two obstructive neurological complications of the disease. About spinal cord compression, I will only say that it's due to a pachymeningitis at cervical level. It's thickening of the dura madre, and also hyperplasia of the transverse ligament that it's, of course, due to the progressive GAG deposit there. And the symptoms, the signs are very important here. You need a neurologist in your team because The neurological examination in every visit should be very careful. The abnormal reflexes are something to look forward, also the muscle strain, of course, and the patients who start developing compression of the spinal cord start with motor problems in the first time, with exercise intolerance, gait abnormality, the difficulty in raising from sitting position, for example, maybe could have some bladder dysfunction. And it's important to know that if you leave this compression there in the natural course, the patient will become in wheelchair and bedridden in maybe a few months or years. So irreversible damage could occur and you have to treat it. How to assess it? Not only by the imaging, but also with the neurophysiologist. So the SSEP, the evoked potential, is a kind of method to see how the conduction is in the spinal cord. It's a good method, it's a gold standard. And the treatment is the decompression surgery. It should be performed by the experienced team of neurosurgeons, have a lot of complications, infarctions, infections. In the very severe patients, you have maybe if the patient is already bedridden, you can take an ethical decision there not to treat, but you need to treat it when diagnosed very quickly. If you see in a pediatric patient the CTS, you should think in MPSs because it's not common in the children. And it's a neuropathy, it's an entrapment neuropathy of the median nerve in the wrist due to specifically soft tissues deposits. And it's much more common maybe that we think. The Korean group in a very recent publication, they look actively in a population of 45 MPS II patients to CTS with nerve conduction studies, and almost all the patients have some abnormality at very early ages. So I think we should look for actively this entrapment neuropathy in our patients in a regular basis. The problem is that the nerve conduction study, it's an invasive problem, and it's an invasive procedure, and that limits the use. So there's no easy in MPS to do the diagnosis by clinical signs, but you need the nerve conduction or the new approaching method that is the ultrasound. Ultrasound appears to be a good method, correlates with the electrophysiological abnormalities, but needs a very experienced operator. Not any center has experience doing that. I think should be validated in the next year, but could be a good solution for our patients. So the compression surgery is quite simple, and it's the solution if the impairment of the conduction is still mild, but remember then the earlier the better. If the nerve is completely damaged, maybe it's too late for recovery. And remember that recurrence is possible. You can operate the patient and many years ago could appear again. Remember a summary that you should have a good neurologist very close to you if you want to treat 100 patients, because the manifestations in terms of peripheral and central nervous system are many, and many of them are very, very severe.